complex stroke and cerebrovascular surgery as something we do in a tertiary care center. And this is very important because, actually I came here before Dr. Decker. That's true. I started exactly in April of 2012, right when Florida hospitals bought or acquired this facility from previously known University Hospital, so UCH. So I started right with the Adventist here in this hospital, in this facility, which was a community hospital. What is it that entails turning a community hospital into a tertiary care center? There are many things, but in our realm of things, it's very important to understand that tertiary care means you should be able to do everything that needs to be done for a patient in this facility. In the realm of neurosurgery and complex stroke, that can be very fancy. That can be very challenging, and that requires a lot of compromise from not only administration, but all the services that have to do with this. Intensive care, stroke neurology, the OR, and obviously the neurosurgery service. As part of USF, skull-based division, I am a skull-based cerebrovascular surgeon, finished my fellowship in USF in 2010, and then I've been here since 2012 working to try to take AdventHealth Tampa up to the level of any other hospital in the state or the country. That's, not to say that only Tampa General Hospital and St. Joseph Hospital, Maine, are the ones that can do pretty much the same things we do here. So we're kind of like the third big player in the Tampa community, trying to do what we need to do for our patients. So why stroke? And stroke is very important because you got to understand, what is a stroke? And, it's, the word has an impact, right? It's a stroke. But in reality, it's the same mechanism as when you have a cardiac event, like when you have a myocardial infarction. Everybody is very well versed in cardiac problems because I think the 20th century was the heart century. They developed the cardiac bypass surgery. They developed all the stenting, angioplasties. I mean, it was amazing what they were able to do from the 1950s all over to the early 2000s, including the cardiac transplantations and all these other things. I think that in the neuro part of medical care, we came a little late to that, and we actually learned from them. We kind of like take it from when they left it off and started to project towards the future in the shoulders of the cardiology advances. The first stents that were ever used and intracranially were cardiac stents that were just extrapolated and put inside of the brain. And on top of that, the brain, the stroke, the neurosurgery applied to complex stroke is very, very dependent on technology. We would not be able to do what we do today if we wouldn't have the advances in computers, the advances in imaging especially, and all the other things that we have in the OR, the technology to put, coils or stents and things inside of the patient's brain. It would not be possible if it wouldn't be in an advanced technological society. Now, when do neurosurgeons come into play for stroke? Stroke is important as a health problem in the States, in the world, especially in industrialized countries when population ages, and then you have all these risk factors that can predispose patients to get different kinds of strokes. And it's very important that you will understand today the two major kinds of stroke and why they need a neurosurgeon, because after I finish my talk, it's going to be all neurology, interventional radiology, and everybody else is going to be talking about that. They're not going to say anything about surgery. So I'm the one that's not talking. It's going to be talking about surgery, and I wanted you to understand how that is important. Every 40 seconds, somebody has a stroke, and every 4 minutes, somebody dies from a stroke. So being a comprehensive stroke center, being a center of reference for complex stroke is very important. We have now a network of hospitals that refer all their patients to us, and we're proud of being able to bring that service. It's the leading cause of disability and job loss and revenue loss in the market, in the job market in America today. Now, if there is one slide that I want you guys to take home today, is this one. And I'm not going to talk, it's important, but I'm not the one that is supposed to be talking too much about this, because these are the warning signs of stroke. When to suspect or recognize a stroke. And it's, basically when you have a sudden problem. It's when there is something that is not right, that is usually focal, meaning lateralized, meaning one side is better than the other or not. So, sudden numbness, weakness on the face, arm, leg, one side of the body, sudden confusion, trouble speaking or understanding, sudden trouble seeing one or both eyes, sudden trouble walking, dizziness, loss of balance or coordination, sudden severe headaches with no known cause. Every time you see those things, you should alert a stroke. Big differences. There are two kinds of stroke, and that's very important. You have the ischemic stroke and you have the hemorrhagic stroke. And they're both strokes because the brain is, remember this, like real estate, right? Location, location, location. So when you have a symptom, a neurological symptom, the most important thing is the topographic diagnosis, where this symptom might be coming from. So once you localize it, then you look for the cause of it, the etiology of the stroke or the symptom. Could be a tumor, could be an ischemic stroke, could be a hemorrhagic stroke, could be vasospasm, could be TIA, could be many other things that they're going to talk about, the other doctors are going to talk about later. But in our talk, we're going to focus on this too. If you can see those images of the brain there, when you look at the brain from this coronal cut, I don't have a laser, but when you look at it from the front, you have the carotid arteries, the ones that are next to your trachea here, that go inside of the brain through the skull, and as soon as they get inside, that divide in two. One branch you can see there goes towards the center of the head, is the anterior cerebral artery, and the other one goes to the side. In these two brains, you can see the branch that goes to the side between the frontal and the temporal lobe has a problem. On the image that has the ischemic stroke, you can see there's an obstruction. There is a lack of blood supply in the area that is supposed to be supplied by that artery, being redundant. So that area cannot survive without the oxygen. The neurons can only be without oxygen at around 3 minutes, and then they die, and that's when you have the symptoms. Same thing would happen if you have a hemorrhagic stroke, but in this case, it's not because of lack of oxygen, because of an obstruction of the blood flow, but as opposed to that, because there is a spillage of blood. There's a rupture in the vessel that creates the damage in the cells in that area. Very important to remember, and this is something I have from like my first years of med school, when we used to do cadaveric dissection, and we were cutting brains, and the cadaver lab, you would see patients that will have died from any other reason, but when you were doing cuts, you will see a hole in the brain. Those holes, old strokes, especially if they're hemorrhagic. Ischemic too, they go into what is called liquefactive necrosis, meaning that the tissue that dies becomes water. And the blood also does that to the brain. It's like acid to the brain. So the cells that are initially damaged, they're lost, and there's a hole in there forever. So why is this stroke so important? Why time is brain? Why do we have to act fast? Because if it's only 3 minutes that you have for those neurons to survive without oxygen, because of all the other cells around it that are not dead, but they're not working well because there's an injury close to them. And there's a lot of factors and chemical factors, cytotoxic, etc. Sorry. You will have to spare my hands, right? I'm from Cuba, just if you guys don't know, it's a joke. You know how to call a Cuban with no hands? Mute. We use them to talk. So I need that, okay? Sorry. Especially when I'm tired. So this is what happens. All those cells now are not working well. Those are the cells that we need to save. We need to minimize the damage, the permanent damage. And those are the cells that if we recover the patient, eventually return the function with rehabilitation, et cetera, and those are the patients that improve. They initially have the stroke with a big hemiplegia, then eventually they will recover mostly the leg, less the arm, but that's why you can see the return of function sometimes. Very important concept to differentiate the two because they have different sources. When do you have an ischemic stroke? You see it there. There's a blockage. Blockage could be of two main reasons, right? Either something that grows inside of the vessel, like a plaque of cholesterol, atherosclerotic plaque. It grows, is that yellow little thing there, just to remind you of fat. And then it makes the arteries stenotic, and then the flow gets decreased. But the more important thing is that behind that plaque, the blood creates turbulence, because the blood inside of the vessels is like it's supposed to be in what we call laminar flow, right? It's supposed to be going smoothly in a very smooth pipeline. When you have something, an irregularity inside of that pipeline, behind it becomes the turbulent. And that's when the platelets aggregate and you generate blood clots. And then, same thing happens in the heart when you have, AFib, not an effective contraction. You have all those little blood clots and then shower your brain. So it's very important to know that's one aspect of it. And the other aspect is basically a blood clot or a piece of atherosclerotic plaque that just dislodges and travels and then gets stuck in a narrower vessel. And that's the difference between a thrombotic or embolic stroke, although they are, interrelated. And then obviously the rupture. We all know how important it is to control the risk factors about, hypertension, smoking, alcoholism, drug use, and all the things that we can prevent to avoid vessel fragility and increase high blood pressure that will make those vessels to bleed. That is why when you have a patient that suffers either a TIA, suspicion of stroke, kind of like the red flag for this stroke that's coming, or a true stroke, then you have to do a full workup. You start looking on the carotids, right? Because there's a bifurcation. The common carotid that goes into the neck divides at some point here in the external carotid that goes out in the outside of the head, and then the internal carotid that doesn't have any branches except for inside the brain. And at that bifurcation, naturally, you would have some degree of turbulence, and naturally that's where you have some plaque deposits. So when you study this, then you can know if the patient has a risk factor for carotid stenosis, embolic stroke, or a thrombotic phenomenon. Then you also have to study the heart. Same thing I was saying about having AFib, etc., or when you have like a patent foraminal valley and have a blood clot that even can come from the legs, and instead of going into the pulmonary circulation, they can cross over to the systemic circulation and then go up into the head. Things that you gotta keep, in the back of your mind. Normal brain with a stroke. CT scan is not the best tool for us to identify strokes, because only you would see a stroke like that when you have dead tissue, when that brain has been deprived of oxygen for a certain amount of time. You see it like this usually after 24, 48 hours. Although a stroke that big, you might be able to hint it, from the get-go. But you usually try to use MRI, because MRI has so many different sequences that can actually tell you the level of functioning of the cells inside of the brain, and will tell you if there is lack of oxygen in certain areas of the brain, and it will be really, really your diagnostic tool to diagnose a stroke or not. This is when, unfortunately, we have to play a role. It's when the stroke is so big, it swells so much, then it compromises the patient's life. All you guys imagine the skull, right? And the brain is inside of there. It's a closed cavity. There are only three things that are supposed to be inside of your skull. For most of us, I shouldn't say that. For everybody, you should have brain, right? And then you should have blood, and you should have fluid. So those three things are the normal things. If one of those things increases, then there's not enough space for the other. Or if you put something in there that doesn't belong in there, like a tumor, like a bullet, like an axe or a knife, or we can get all dramatic if you want to, those things don't belong there. That creates what? Pressure. Since it's a closed cavity, you can only have so much pressure in there until the heart cannot pump the blood up. Once the pressure in the head is so high that the blood cannot go in there, you become brain dead because of a lack of oxygen to the whole brain. So that's when the neurosurgeons come and say, well, I'm going to do a procedure that's going to save the patient's life. We're not going to cure the stroke. We're not going to improve the stroke. The symptoms are already there. The brain is already dead. But at least it's not going to swell to the point that it's going to compress the brainstem and be fatal for the patient. So we do a decompressive craniectomy so that that brain can swell out of the head. And then when all that brain dies, eventually it comes down because it becomes fluid, it becomes like a hole. And then when initially you have a very, very tense skin flap with the brain pushing, eventually it recedes and it goes inside of the head and you have an excavation. You might have seen one of those patients around there in which we put the bone back when the patient's ready for it, usually between 3 and 6 months, because it's got to be completely healed, the patient's got to be completely stable. Different ways of doing it. If you plan for it, you can prep the belly of the patient, put the bone in the patient's abdominal wall, which is good because the patient carries his own bone and is sterile. Or you can send it to the bone bank, which gets classified and frozen, and then I usually do that when I don't plan it, when I have an intraoperative event that makes me decide to give the bone out, and then in those instances, then I send it to the freezer, because in the past I have had trouble with the bone sending me the bone that it doesn't belong to the patient or something like that. I want everybody to have their own bone back. This is the hemorrhagic stroke, classic basal ganglia / thalamic hemorrhage for a hypertensive emergency. As you can see on the CT scan, the blood looks white, and if you can see there, the ventricle on the right side is being pushed, it's being compressed. Still, they're very minimal midline shift. We're very careful about those words, midline shift. Why? Because things that have to be at the middle have to be in the middle. The brain is like a very sophisticated, fancy lady, right? You cannot really offend that lady. You can probably convince her if you're patient enough and you try this and you try that little by little. That's why you can get big tumors, to push the brain a lot with very little symptoms. But if you do it suddenly, if you try to force that lady to do what you want to do, she's going to say, stop, right? And I'm not mean, to be sexist or anything like that. It's just the nature of the brain. Sudden insults are not well tolerated. Slow and progressive pressure gets tolerated a lot better. So when you have things in the middle that get pushed, not good. What happens in the middle, you have your brainstem. That's what is a very small structure, the size of your thumb, but it's like a huge relay station. The brain up here, brainstem here, and then the spinal cord. Everything that goes from the brain down to the body has to go through there. All the information that comes from all the receptors in the body up into the brain have to go through there. So that little area, real estate, location, location, location. Small tumor there, small stroke there, small injury there, huge effect in the rest of the body. This patient that we've been trying to keep alive all night long, I just came from there, had an event, an anoxic event, was almost coding, blood pressure was 60/20, the ICP was in the 40s, he could not oxygenate, has huge pulmonary edema, it's a patient that has a cardiac problem. Now after he was stabilized by the intensivist, his pupils are dilated, they're fixed, they're not reacting to light, he's got no corneal reflexes, he's got no gag, no cough reflex. What does it tell me? It's telling me that something happened, that now the brainstem of that patient's not working well. So until that, he had, we put a ventriculostomy in the middle of the night, the pressures were in the high teens, low 20s. We were managing, trying to get him to the angio suite so we can diagnose him with what we think he has, which is a ruptured aneurysm, and see if we can treat it. We're gonna go with that later. Right now, things have changed. The patient has florid pulmonary edema, could be from the brain injury, could be from the heart that's failing, he's got a quadruple bypass, and then there was no oxygenation, and there was increased pressure inside of the brain. That brainstem may have suffered, maybe an irreversible damage, we don't know yet, but if you have no brainstem reflexes, that means that you're approaching brain death. So that you can be in a coma, you can be completely, not responding, not following commands, but as long as your brainstem works, you should be able to recover somewhat. You could have some focal deficit, hemiplegias, etc., but you should at least recover your consciousness and be somewhat functional. When you have brainstem damage, things change. That's why midline shift is so important. Going back to the initial point, when the midline shifts, the brainstem gets compressed, no blood flow there, brainstem dies. That's how patients die. This is exactly, and I will show you probably if I have the time, because when I get a little excited, I talk too much. This is what this patient had. It's a subarachnoid hemorrhage. You see the pattern of the blood is totally different. It's not intraaxial. It's not inside of the brain. It's extraaxial. That's why it's called subarachnoid. You can see how it spreads into all the fissures and it's all the spaces in between the brain. It's not inside of the brain. And you always think of the brain as being inside of this cavity, the skull, that is just closed and compact, the black box that you should not be opening, that we do because we can. And then you have the brain suspending in this fluid, the cerebrospinal fluid. The cerebrospinal fluid is contained into this membrane, this sac, that is called the arachnoid. And it's called arachnoid because the Greek looked at, the Spartans when opening hands with their swords, etc. They saw that those brains had this little spider web around it, very thin membrane that all the vessels are inside of it and is filled with this fluid. So when you bleed in that space, you have a subarachnoid bleed. I'm going to go over the other different membranes in a little bit. This is the brain that nobody wants to have because there's a little bit of all kinds of hemorrhages in there. There's hemorrhages inside of the brain, outside of the brain, in the epidural space, in the subdural space. There's hemorrhages inside of the ventricles. So that's a pre-mortem scan. Now, what are the other membranes that cover the brain? You have the dura mater. Now we get a little bit more in history, right? The Greek saw the spider web, arachnoid, because if you're not Greek, you want to be Greek, remember? But now you have the dura mater. Here's when the Romans came in, Latin, dura mater, tough mother, because it's a very tough and fibrous membrane that covers the inside of the bone and actually protects the brain. And then when you have a blood clot in between the bone and that dura mater, that's what you see there. That's why he's got that little lens shape, because this is attached to the bone on the inside. So that blood is basically trying to separate the dura mater from the bone. It's called epidural hematoma. Epi on top of the dura, epidural hematoma. A combination of Latin and Greek, and they're all mixed up. Greco-Roman culture, right? So this is usually due to an arterial problem. Usually you have a fracture on your bone, middle meningeal artery that runs underneath the skull. When we do surgery to take the skull off, you can see the impression of the artery in the inside. And then it's the classic kid that was playing baseball and got hit with a ball on the side of the head. I was fine. 2 hours later, he's herniating and dying because this is an arterial pumper. Arteries never collapse. Even post-mortem, they're still open. You can see the hole inside of it because they have a very strong muscular layer. They are the ones that regulate their blood pressure. They contract, they dilate, so they stay open. Veins are weak, very thin. They do not do that. So when you have an arterial pumper, it doesn't stop spontaneously. You have to stop it. Otherwise, it will not. Unless, obviously, there's enough pressure that will tamponade at it. But sometimes that pressure is too much for the brain to survive with it, and that's how the patients die. This is what you see when you operate on it. You see the scalp and the muscle out. You see the bone, and then you see the dura mater, which is that shiny, tough, fibrous membrane underneath the blood clot. The blood clot is on top of the dura mater. It's basically between the bone and the dura mater. Then this is the other kind. This is the subdural. This is a very curious case because you can tell on the left side the patient has an operation already. This is the patient that comes with a subdural hematoma on one side, and the other side is very small. You decompress the side that was bigger, and now you don't have any counter punch to the other side, and then the other side now becomes bigger, and then you have to operate on the contralateral side, which I have to do several times in my life. So, sorry. As you can tell, that subdural hematoma has a different shape and it goes along the convexity of the brain. Why? Because it's not on top of the dura mater, which is the one that starts to the skull. It's underneath the dura mater, that is above the arachnoid. So it's not in direct contact with the brain, it's pushing it down. Subdurals can be very impressive because they can basically go around the brain, and they usually bigger. The epidural hematomas can kill you faster because it's an arterial pumper. Subdural hematomas kill you slower. Unfortunately, what happens when you have a traumatic injury to your brain is that when you break your skull, most of that kinetic energy is employed into creating that fracture and breaking the artery that gives you the epidural hematoma. That's why those patients have that lucid interval, right? They're okay because the brain did not suffer damage. And then they deteriorate when the hematoma becomes bigger. Subdural is kind of different. The skull didn't break, or this is a patient that has atrophy, being old, Coumadin, Plavix, aspirin, blood thinners of any kind, and then little by little, that subdural grows, and then, or when you have a traumatic injury, that energy was not spent breaking the bone, it transmits into the brain. So traumatic subdural hematomas have a lot more damaging injuries to the brain than epidurals. And subdurals, when they press, you have to take them out too, because they can, as you can tell, create midline shift and kill you. Now, talking about vascular abnormalities, hemorrhagic stroke in the brain, there are several different vascular abnormalities that we can go over. Some of them are more common, some of them are less common, some of them are very rare. Important to see in this picture, aneurysms. Why? Because aneurysms, even though they're not that common, it's roughly 1 in a million, aneurysms can break and can create a subarachnoid hemorrhage. You see the brain is in that space where the fluid is and the surface of the brain. Again, the turbulence on all the bifurcation points of the arteries, those blood vessels there get weak because of the pumping action of every systole of the heart. Every time that the blood pressure impacts on 120, 100, if you have 120. But those areas are more susceptible to create these kind of balloons. It's like when you have, the inner tires or a balloon, it gets inflated. That balloon is thinner than the regular, already thin wall of the blood vessels in the brain. The blood vessels in the brain are not like the rest of the body. They're thinner. They don't have that much of a muscularis. That's why when you talk about aneurysms in the aorta or the renal artery, different animal. The aneurysms in the brain are unique because they're very, very paper thin and they can burst very easily. Now, very important to understand also that the risk of bleeding of aneurysms is not that high. It's usually 1 or 1.5% per year. So it's not like everybody that has an aneurysm is going to have a hemorrhage. But numbers, again, can be deceiving, the way you look at them. If you're 1 of 100, but you're the one that year you need to bleed, for you is 100%. And when you bleed, we're going to go over that. When you bleed, it's very dangerous for you. 1/3 of the patients don't even make it to the hospital, and they die at home. And then the ones that make it to the hospital is roughly 1/3 makes it through after 21 days in the ICU with drains and operations and coilings and all those things, and then 1/2, doesn't make it, regardless of anything that we do. Then covering the different kind of malformations, so we also have the so-called AVMs. AVMs are the ones that you have an abnormal communication between the arteries and the veins. Normally, arterial blood is never in direct contact with venous blood, right? You have to have the tissue in between. You bring your arterial blood from the heart full of oxygen on the capillary bed. The tissue gets the oxygen, gets the nutrients, and then dumps all the toxins into the capillary bed that slowly goes into the venous side of it. And then the veins take the blood to the heart. The venous system is a low pressure system. That's why it's thin wall and slow. Arterial side is fast. The pressure is what makes the blood moves. And when they communicate abnormally, then the veins cannot take it. You see the vein on the right, how dilated they become, because now they have to handle a huge volume of blood that they were not used to before. And that's when you create aneurysms there, you create all kinds of problems with the blood flow, the regulation, and then you bleed. When you bleed with AVMs, you can bleed inside of the brain, you can bleed outside of the brain, you can bleed it pretty much anywhere. AVMs are very, very challenging. It's one of my favorite operations in the sense that sometimes there's nothing you can do, and it's very challenging. You have to operate on it with the skill of a vascular surgeon, but thinking as a brain tumor surgeon. So you have to combine two different sets of skills because it's basically a tumor made out of blood vessels. And if it starts bleeding, you're in big trouble. Especially because usually the arteries come from the skull, from the inside out, from the base of the skull towards the brain, and the veins are in the periphery recollecting that blood. So usually when you go in, the first thing you see is the venous side of the AVM. And if that bleeds, you know the blood is coming from the deep end of it. So now you have to hurry up and go around and down and try to get to those feeders so you can clip them and get it out. Otherwise, you're never, ever going to be able to stop the bleeding. And those patients can actually die on the table. When you have an aneurysm, the aneurysm bleeds, if you're close enough, you can put a clip on the artery that fits the aneurysm and at least temporize and try to fix the aneurysm as fast as possible so you can take that clip off and the patient doesn't have a stroke. But when you have an AVM, things can get very dicey. Dural arteriovenous fistulas is kind of the same principle, but it's not in the brain, it's in the dura. They can bleed too, but they can be treated a little bit easier and be embolized because usually they have only one feeder. AVMs can have multiple feeders, and AVMs are strange because sometimes you see 3 big feeders and you embolize it and you're like, oh, guy, it's gone. And then a week later, it's opening another feeder from here, from there, and feeders that were not there before because the big ones were supplying the AVM with the blood, but when you took those ones, the AVM sucks the blood out of the smaller ones that you couldn't see before. So it can get very tricky, and that's why sometimes you have to redo surgeries on them. Cavernous hemangiomas, not really that important unless they bleed. It's usually genetic syndromes in people that have multiple. If they bleed one time, you can observe them. If there's no symptoms, if they're big bleeds, then you take them out. But they're not that common, they're not that important. Venous angiomas, there's nothing you can do about them. It's a radiological diagnosis. Even if you do an angiogram, you're not gonna see them. But people go to clinic all the time saying, oh my God, I have a venous angioma. It's like a varices in the brain, but it's not that important. And capillary telangiectasias are like almost microscopic. It's nothing of clinical significance. Now, why aneurysms are so important? First, because it's an emergency. They come in the middle of the night, patients are dying, and this is usually when you have an acute stroke, either ischemic or an acute stroke that is hemorrhagic. Aneurysms is when everything has to be perfect. And I have a case that is still in the hospital. I did 2, tomorrow, Friday, is going to be 3 weeks. That came in on a Friday evening. And I had done 3 cases that day. I was exhausted. I was going home. And when I was like 1 mile from my house, they call me and they say, there's a patient that's coming, sudden onset headache, deteriorated in front of the ER doctor, had to be intubated. They did a scan, has a subarachnoid hemorrhage, but there's a big blood clot on the sylvian fissure. It's midline shift, it's herniated, and I'm like, okay. Turn around, come to the hospital. That patient, pupils were fixed and dilated. He was dying. So you could not afford to do an angiogram. You suspect because of the blood clot being in the sylvian fissure that is coming from an aneurysm. It's not only a subarachnoid hemorrhage, it was a big blood clot that was also going inside of the brain. So you have to first decompress that big blood clot. Second, you're going to have something underneath there, but you don't know what. And third, you have to leave the bone out because that's going to swell tremendously. And in fact, with the combination of the 3 surgeries, patient came in here. By the time I got to the ICU, they were cleaning the patient. Back to the CT scanner, did a CT angiogram, saw the aneurysm. We only saw one branch of the MCA. We knew it was going to have a stroke. And from there, we went to the OR. In less than 35, 40 minutes, we were already in the OR trying to operate on this patient, took the skull off, decompress the hematoma, take the blood clot out, saw the aneurysm. It was a nasty aneurysm. I had to put 4 clips to try to reconstruct it. He obviously had a stroke in the MCA, but he's alive. and he's probably going to recover. He's on the right side, so being on the right side, probably going to leave him with a left-sided hemiplegia, but being right-handed, having 98% of your speech on the left hemisphere, he's probably going to, if he recovers, of course, with all the other complications and pneumonias and bed sores and UTIs, etc., DVTs, blah, all those things, if he eventually recovers from all the potential complications, he could have a meaningful life in the way that he could actually understand language and express himself and have a hemiplegia on the left side, but move the right side okay. That is when things work perfectly, and I emphasize that because it's very important that everything in the hospital has to be very synchronized for these things to happen that way. This is a couple of different aneurysms. Aneurysms can be usually saccular, and we call them berry aneurysms because you have a narrow neck and you have this ball that is where the thin part that goes ahead and kind of explodes. Or you have aneurysms that could be fusiform. Fusiform meaning the whole vessel is dilated. When you have a fusiform aneurysm, there's really nothing you can do about it. You know, sometimes if they're proximal, in a proximal artery, we go ahead and wrap them with tissue or with fibrotic material in order to see if the body can create like a inflammatory reaction and like a scar around it and prevent him from rupturing, but you cannot take the whole vessel. Luckily, most of those fusiform aneurysms happen if they're due to infections, so we call them mycotic. I don't really know why, because they're not due to fungi, but usually due to bacteria. Those happen distally, and very peripheral arteries are not that important. But you can have aneurysm for many other reasons, but those are the most important. The majority of the aneurysms occur in that little square you see there. It's called the circle Willis, because it's the way you can tell the posterior circulation communicates with the anterior circulation. You have a bunch of little arteries intercommunicating, so there's a lot of traffic. There's a lot of intersection. There's a lot of flow that diverges one way or the other. Sometimes we have to take one of those arteries and then the flow goes the other way and reroutes and changes the whole hemodynamic of the blood circulation. So those are things and details that we have to take into account when we're going to do these operations, because sometimes you have no option but to take the artery. And sometimes you feel safe doing that when you know the blood's going to come from somewhere else. That's the way of nature to try to avoid strokes. But at the same time, is where you get all these aneurysms because of that many diverging points. Like we said, you know, this is all statistics. We talked about that already. Important to secure the aneurysms. This poor patient that just came in the middle of the night, we did a CTangiogram because it can be done at any time and it's not invasive. We know the patient has an aneurysm in the internal carotid. Now, unfortunately, he's so unstable that he cannot even get out of the room to get another scan or go to do the angiogram. But why is that important? Because a second bleed, 80% mortality. So if the first bleed is 33 or 40% mortality, the second bleed is almost fatal all the time, 4 out of 5. So you want to at least make sure that that aneurysm is not going to bleed anymore. Either you coil it like this, in which you put a microcatheter all the way from the groin or the radial artery inside of the brain, and then you fill that dome with these platinum coils, so the blood inside of the aneurysm becomes stagnant and clots off, and then it doesn't bleed anymore. Or you do other things like stent coils. If you have an aneurysm with a wider base, that you cannot put coils inside only because they will not stay inside, and some of them will fall back into the blood vessel. If they fall back into the blood vessels, obviously, they can create strokes downstream. So sometimes you keep them inside with a stent, or more recently, we have advances that probably Dr. Leffler is going to talk about in the way of what we call the pipeline stents. You can see those stents are different from the other metallic stents, that they're so very tightly woven that it's like a fabric, and then the blood doesn't really go through them, and then you're basically creating a vessel within the vessel. That way, that aneurysm that has such a wide base doesn't get blood supply and eventually clots off and dies. Important because sometimes you have aneurysms that have blood vessels coming off of them, and those are the patients in which you say, surgery went very well, we were able to clip the aneurysm. Unfortunately, the patient has a stroke. and has a stroke because the blood vessel was coming off the aneurysm. And if you're going to clip the aneurysm, that blood vessel is going to get clipped. And that blood vessel did not have the luxury of having another vessel rerouting blood to supply that area of the brain. Sometimes, like in the case of the patient I did like 3 weeks ago, you reconstruct the aneurysm. I had to put like 4 different aneurysm clips in order to leave an outflow for that only vessel that was still remaining. The other 2 branches were already gone. So, but at least not to give them a complete MCI stroke, you kind of like reconstruct to leave a little bit of that aneurysm with that the blood can go through. But sometimes you just cannot do that. Sometimes you just have to put a clip on the artery and bite it. There's no other way. So very, very important. This is what we do when we are lucky enough to have an aneurysm that looks like that. What happens is that as we get older, and this is a technological race, right? It's a moving target. When I started my training back in 2002, 2003, we were basically clipping everything. I mean, we're at the beginning of the coiling and stenting era. It was in 2003 when the big article in the European journal, The Lancet, came out about the studies done in Europe in which coiling and stenting was better than clipping. So it was a very big controversy on the neurosurgical world. But in essence, now we're only clipping the very, very difficult aneurysms. All the aneurysms that look like that, they're very easily coiled, they're very easily stented. So in the past, as you know, you used to clip more aneurysms, and you know, you get to clip a lot of the easy ones. So when you get the real bad one, you were very well trained. And these days, aneurysm surgery is becoming very, very rare. Very, very few neurosurgeons do it because they're less common. The ones that get to you are the ones that the interventional radiologist cannot coil or stent coil. So usually in a very awkward location, usually with multilobulated and odd shapes, or in areas where the vessels are very dangerous and they don't want to cause the stroke. So yes, of course, they don't want to cause the stroke, but then we have to cause the stroke. So sometimes you have to sit down and say, well, what's better for the patient, to get a stroke without a surgery, or to get a stroke anyway with, on top of that, a big brain surgery? And that's when you have to sit down and collaborate with your colleagues and see what is going to be ultimately better for the patient as a whole. That's an aneurysm clip there. This is when you see the aneurysm before the clip. This is the aneurysm after the clip is put in. This is a case that I did in this hospital some time ago, in which you can see right at the center of the head. This is a right carotid view. You see the MCA to the side, you see the ACAs at the center, and right in between the 2 ACAs and what we call the anterior communicating artery, you see all these multiple balls there. You know, this is how you open the brain. It's how you go in between the frontal and temporal lobe, and the Sylvian fissure we call it, and then you get back there. The other thing that I wanted to show you is that sometimes, even though we're just surgeons, we try to be considerate. You know, this is that patient, and we actually did the surgery without even shaving any hair on her, because she was very conscious about the fact that she didn't want anybody to know that she had big brain surgery, and she didn't want to be bold, and you know, so we were able to do that. If you unfortunately don't have much hair, like some of my friends here, we don't have to be that careful. This is another aneurysm. You can see it coming down and to the side. It looks like a boot. I don't know if you can see it well there. Wish I had a laser pointer, but that how it looks, you see it white, because that is a very, very dangerous aneurysms, because those aneurysms, when you see them white like that, it means they're calcified. When you have calcium inside of the aneurysms, then you have to be very careful, because if you put a clip and you crack that calcium and that takes the wall with it, you can close it. That's it. You have a hole in the artery, and it's rigid, so you cannot collapse it. And that way, you know, this guy, we got lucky in this guy. And this is a picture that I took from the microscope when I did that aneurysm. This is one of those patients, and you can see, very important for me, that we did the incision behind the hairline, because still, when you have a receding hairline, we'll consider it. And important that you can see how he can elevate both eyebrows. It's very usual that, for this kind of big surgeries, when you have to take the temporalis muscle down, the frontalis branch of the facial nerve that goes to elevate your eyebrow gets stretched. We never see it. We know where it is. We try to spare it, but sometimes we can. And usually it's transient if you have a paralysis. Sometimes it's permanent. And if it's permanent, then, the patients come to me and say, okay, can you do the other side so I can be even? I don't have any forehead wrinkles anymore. And I'm like, no, you're going to be asymmetric for the rest of your life. This is the other patient that we did. That again, you don't see the incision. She doesn't have a deficit. So those are the things that on top, sometimes you have to do surgery, which is a savage surgery, and just to save the patient's life, just to clip the aneurysm no matter what, in which case you just go at it. Sometimes if the aneurysm, you're lucky enough that you can capture it before it bleeds, then you can be fancy, you can be careful about other things and give the patient a much better experience. But that's why we try to operate an aneurysm where they are unruptured. Operating on a swollen, bloody, angry brain on a patient that is dying is not fun. We like it because we like the suffering, but it's not fun. This is actually a very interesting case that I did several years ago, in which you can see right in the center of the head, that artery that's supposed to be a straight line up, how you have that like a little blush of blood there with an abnormal artery going around at the bottom. That's an AVM. An AVM that was operated by a colleague of mine at Tampa General on a very young teenager, and it grew back up because, again, the same thing. Some of those smaller feeders that were not detected at the time opened up, and eventually that part of the AVM that we didn't know existed showed up. That AVM has an aneurysm at the bottom. If you see that little thing, looks like a little boot at the bottom of the arterial blush, and that's inside of the ventricles. It's a very difficult surgery because we had to go through the center of the head, in between the hemispheres, through the corpus callosum, inside of the ventricles, like 10, 12 centimeters down, and try to get this out of the ventricle and find the feeding vessel that, as you can tell, comes from the bottom. So it's all the way behind us. And we went. Again, beautiful girl. She didn't want to, go back to school with a bald head. So we went through the same incision as the other surgeon, and still spare out her hair. She was very appreciative of that. This is a picture that you very rarely see on a live patient, because that red thing you see at the bottom there is the choroid plexus, which is the blood vessels that are modified blood vessels inside of the ventricles of the brain that produce the CSF. You usually don't get to see them live like that. And this is part of the AVM and the blood clot that we took out of the ventricle. And you can see there how the blood clot is next to the choroid plexus. So we were able to get it all out, and so far, like 5 years after that, she's still going strong with no residual AVM. So very, very important. We went over pretty much everything, regarding ischemic stroke, hemorrhagic stroke, the different modalities of hemorrhagic stroke, the different types of ischemic stroke, how neurosurgeons are involved in these kind of cases. But I want to emphasize, and never emphasize it enough, that what we want to do is collaborate. We need a united team. We need everybody to understand that we're just part of the team. We cannot do what we do if we don't have intensivists, if we don't have intensive care nurses, if we don't have the people in the OR, the schedulers, if we don't have an ER that acts fast, or the people in the CT and the radiology department. So the coordination of all these efforts is so important. Without them, we wouldn't be able to do anything for the patients, regardless of our level of skill or our technical abilities. Okay, so like I said, it's difficult, but at least we have to try to have a life outside of this, although this can be very, very addictive. satisfaction, the results. Every time we see a life that we can save, we feel that we've done what we were supposed to do, and I don't regret one time of not having enough sleep. I don't regret one time that I have to call my wife and tell them that I cannot go home, that I have to go back to the hospital, because I know that what we're going to do in this facility for those patients, very few people can do, and very few facilities can provide. So that's why it's very important that we do these events and provide education for all of you guys, so we can have a better understanding and more help from you guys. Again, like I said, I move my hands a lot, I'm loud, I speak fast. English is not my primary language, but I hope that you guys understood what I said and that you can cooperate with us trying to push this program forward, okay? Thank you very much.